It's now my very great pleasure to introduce Laura de Graaf. Laura is a practicing adult endocrinologist. She is the Associate Professor of Genetics and Developmental Endocrinology at both the Erasmus and Redbound Universities and Medical Centres in the Netherlands. As a founding member of the Centre for Adults with Rare Genetic Syndromes, she led both clinical research and investigation into biomolecular pathways and cellular mechanisms involved in rare disease. The multidisciplinary team takes care of over 1,250 adults from 19 nations in their reference centre, which includes over 200 people living with PWS. Dr. de Graaf has also initiated the International Network for Rare Management and Education of Adults with PWS. This large international network has been very active in the last 5 years, resulting in the publication of 8 articles with particular recommendations to improve clinical care for adults with Prader-Willi syndrome. So, to speak on growth hormone for adults with Prader-Willi syndrome, we have a pre-recording presented by Laura de Graaf.
Hello everybody, my name is Laura de Graaf. I'm from the Netherlands. I'm an adult endocrinologist and I'm doing a lot of growth hormone treatment in adults with PWS, and I want to tell you something about that. These are my disclosures. Let me start in the beginning. We know that children with rare genetic syndromes are getting older and older, and well, more and more they're becoming too old for the pediatrician. So that's why in 2015, when I finished my clinical training, the pediatricians asked me to start a multidisciplinary clinic for young adults with rare genetic syndrome, and that's what I did. So we're now taking care of like 1,200 adults with rare genetic syndromes, and we see over 200 adults with Prader-Willi syndrome. As you know, there are like 2 kind of generations of PWS. The older PWS who have not had multidisciplinary care and growth hormone, they are, well, sometimes very obese, sometimes their cognition is poor, their quality of life can be poor. And most of the time, the young adults that are now young or becoming young adults are really in a different shape. So they, their mobility is better, sometimes their cognition is even better, their quality of life is improved. So that's really, let's say, an achievement also of the pediatricians, that I think we as adult doctors are have the responsibility to take over that multidisciplinary care and to make sure that they don't fall back into the old situation. So that's why I started this multidisciplinary outpatient clinic in 2015. And this is like a pie with 4 pieces, talking in Prader-Willi terms. My piece of the pie is a left upper part, which is the hormone deficiencies. We all know that people with Prader-Willi syndrome can have all kinds of hormone deficiencies, and my task is to treat them and to make sure that they don't have undetected hormone deficiencies. Then on the right, in the upper part, is the dietitian. We know that people with Prader-Willi syndrome have a low rest metabolism. That means that due to their low muscle mass, they don't burn as many calories as people without Prader-Willi do. And that's why if you give them a normal diet, they keep gaining weight. So you really have to put their diet to like 65% of a regular diet, and then they won't gain weight. But yeah, you have to have a, let's say, specialized dietitian to do that. At least that's what my opinion is. So that's also part of our team. Then on the lower right, we have the neuropsychology. That's really important in Prader-Willi syndrome. We know that people with Prader-Willi syndrome can have really strong verbal skills, so they can talk quite well, and then people think they are more intelligent than they really are, or that they understand more than that they really do. And that can cause a lot of stress. This overestimation can cause a lot of stress. And if they are stressed, well, they are not willing to exercise, or at least that's what we see what happens. And if you want to treat obesity and prevent complications, they should exercise. So that's why the neuropsychologist is also part of the multidisciplinary team. Then the physical exercise is important, but sometimes the mobility is poor due to edema or scoliosis or hypotonia. So the physiotherapy is also very important in Prader-Willi syndrome. So this multidisciplinary care has now been in the Erasmus MC for almost 10 years. We have a multidisciplinary team, which is coordinated by Kirsten Davidsen, who is there with you. Of course, I would have loved to be with you as well, but I couldn't travel this time. So next time I will be there as well. And with this multidisciplinary team, we have seen over 1,250 new patients in the last almost 10 years, and 200 of them have Prader-Willi syndrome, as I said. Well, we have a growing network in the Netherlands of internist endocrinologists who are also willing to see adults with rare genetic syndromes, and we try to help them to get started because the waiting lists are huge and there is a lot of new patients coming up. So, and to get them going, we make all kinds of practical recommendations, not only about Prader-Willi syndrome, but also about other syndromes, and they really have that on their table, on their desk when they're seeing new patients, so that really helps them to get started. We have also made one big overview article about all syndromes that we see in the outpatient clinic. We see over 120 different syndromes. And in this article with pictos, we have all the problems that are part of that syndrome so that they don't have to, as we say in Dutch, invent the wheel themselves. We also have made a website with the features of all the syndromes, and that's how we try to help other doctors to get the same type of patient care started. Many of the recommendations that we published about Prader-Willi syndrome are part of the thesis of Carlijn Pelikaan and Anna Rosenberg here in the pictures. So if you want, you can scan the QR codes to read their thesis, because it has a lot of important and practical information that you can also give to your colleague or to your doctor. Well, most part of that research was possible thanks to the collaboration with the Informed PWS network that we started about, I think, 6-7 years ago. That's a large international network of adult endocrinologists, and we take care of about 800 adults with PWS. So we can gather all the data, we can compare the data, and then we can really draw conclusions about what's the best treatment, what's the best way to treat adults with PWS. Now about growth hormone. Many people think that growth hormone is meant to make you grow. That's in part true, but only for the children. And in adults, it's still very important. So if an adult has growth hormone deficiency, a lack of growth hormone, that really changes a lot. So growth hormone is important to keep your brain healthy, so to keep your cognition well, to give you energy. So it helps to reduce fatigue. It lowers your cholesterol. It improves your cardiovascular health. It improves your muscle mass and muscle strength, and it lowers your fat mass. So growth hormone is really not only meant to grow, but it has a lot of, it's like a youth hormone. It keeps you in shape. Now, there has been a lot of discussion about how to test growth hormone deficiency in adults with PWS, because many of the tests that can be used to test for growth hormone deficiency are quite impossible in Prader-Willi syndrome. So I really think we have to stop thinking about. So one of the strongest pieces of evidence that we have is a meta-analysis that we published in like 3 years ago, and it gathers all the articles that have ever been published about growth hormone treatment in Prader-Willi. So also the important large study from, for example, Charlotte Hoiby from Sweden, but all the other important studies are there, and they have been collected together, analyzed together. That's what a meta-analysis does. And then you have all the evidence in a row, all the evidence got together, and then we really saw that growth hormone improves almost everything. It improves your lean body mass, that is, let's say, the muscle mass. It lowers the fat mass, it lowers obesity, it improves cognition, and it does a lot of things. It has a lot of benefits. And it's not only the meta-analysis and the statistical analysis that shows us that growth hormone really helps. It's also what we see happening in the outpatient clinic. So this is Marco. Marco, well, knew he had to walk with his dog, but his dog was always much more enthusiastic than he was, because Marco was really tired and he didn't have good exercise tolerance. And then we started him on growth hormone, and then so many things changed. His parents were really, the first time they came back to the outpatient clinic after he had started growth hormone treatment, they said, wow, for the first time in many years, he can climb the stairs. His legs are strong enough to climb the stairs, and he can climb 3-4 stairs at one time. So they really noticed that his muscle strength had improved, and because his muscles were stronger and heavier, he was burning more calories the entire day, so his basal rest metabolism had gone up, and that's why his fat, well, almost disappeared. And that's, well, not the only evidence that we have. We also see, we have done a study and looked at 2 kinds of cohorts with Prader-Willi syndrome. One group who had growth hormone treatment and multidisciplinary care as a child, and the other group had not. Of course, it's important to mention that most people who get growth hormone also have multidisciplinary care. So you never know what is the benefit of growth hormone itself and what's the benefit of the multidisciplinary care. But you cannot separate them, because that's how it, at least in the Netherlands, how it works. You only get growth hormone when you visit a multidisciplinary outpatient clinic, because the other smaller hospitals just don't prescribe growth hormone. But this is a study that Carlijn Pelikaan did, and she compared 2 groups, one with growth hormone and multidisciplinary treatment and one without. And she really saw that there was less obesity, less diabetes, less cardiovascular problems. And I think this has really, those 2 articles have really convinced that all the adults with Prader-Willi syndrome should have growth hormone. Of course, if they don't have any contraindications, because if your BMI is too high, or if you have diabetes that is not well controlled, or if you have sleep apnea, of course, then you cannot use growth hormone, because then it's dangerous. So you first have to tackle the diabetes, you first have to treat the sleep apnea, and your BMI has to be below 40, and then you can start growth hormone, at least in the Netherlands. Well, another important thing that we're doing now is looking at aging, because we saw a remarkability in the Netherlands that the people who were not using growth hormone showed premature aging, and the people who were on growth hormone treatment, they did not have premature aging. And we also saw that in other European countries. So we are now doing a study on the effect of growth hormone, and we are not only looking at the metabolic effects, as I just showed you, but also at the effects on aging. And we are looking at aging parameters in the clinic, like muscle strength and the skin, etc. But we are also looking at aging at the cellular level, so at the DNA level. Because there are certain techniques that you can do to see how old your cells really are. What we are doing is we are linking the cellular aging parameters, the cellular aging markers, to the clinical aging markers. And I hope that really helps us understand what really happens in those patients who are aging prematurely. And we are comparing the ones who are using growth hormone with the ones who are not. So I will not tell you the details, but it's a very interesting study. And we're working together with the University of Valencia in Spain, because they have a long history of aging research, and they have all the expertise that they need. So that was what I wanted to show you about growth hormone and Prader-Willi syndrome. I could tell a lot more, but I only had 15 minutes, so I already have to stop talking. Of course, all the things I showed you, I could not have done it all by myself, so I want to thank all my colleagues. We are posting a lot of things on LinkedIn, so if you like, you can scan the QR code. I hope they send around the slides, because I see my movie is in front of the QR code. But follow us on LinkedIn, and this is my team. On the left, Jacqueline Goos, then Janneke Baan, then myself, and then Kirsten Davidsen, who is with you there. I'm really proud of this team, and really proud of how we're working together. And well, I would say I'm happy to answer any questions, but at the moment that you hear this video, I'm probably sleeping. So you can send your questions to praderwilli@erasmusmc.nl, and I hope to be there with you another time. Thank you for listening, and bye-bye.
Now we have got just a couple of moments for questions. And to answer questions on behalf of Laura, I welcome Kirsten Davies to the lectern.
Hi, James. My question's actually for you. Lynette, mother to Nicola, 17. I just wanted to know, where are we at with being able to get adults with Prader-Willi syndrome a higher dose of growth hormone on the PBS? Because at the moment it's very minimal.
They can get any dose that I prescribe. There's no limitation.
We're paying the difference. We're paying privately.
Sorry, for adults, you shouldn't be. So there's two things. First of all, if your child or your child has had glucagon stimulation testing, which is the least invasive way to measure growth hormone deficiency, and they have growth hormone deficiency, they are entitled to the dose they need. So if you want to direct me to your doctor, I can talk to them.
The problem is they're probably not growth hormone deficient, because she was on it since she was 3 months old.
She could be growth hormone deficient. How old is she now?
17.
We had to do it by an age.
Yeah. Yeah. Well, it's not. It's not. Okay, so it's not correct. So strictly speaking, you have to demonstrate growth hormone deficiency beyond the age of 18, is how I understand it, in order to keep on getting growth hormone treatment. Right? So that means provocative testing.
I guess because they're not 18, they're still under the kids one. So once you hit maturity under the kids one, they put you on the maintenance dose, which at the moment is about 0.03. So we're paying the difference to make it one. So we're paying.
It seems to be an arbitrary calculation.
Yeah.
How they come up with that, because the different weights vary from state to state.
Yeah. So 0.3 is the current dose.
Yeah, just to be, 0.03 is not even a sufficient dose for young adults.
No, that's why we're paying privately.
No, you mean
to get it.
You mean 0.3,
0.3.
not 0.03. 0.3.
Oh,
So we're paying privately.
0.3. That's fine.
3.0.
For adults, that's fine. 0.3
Yeah.
for most.
Uh,
Okay, so I'm not sure about the 17 to 18-year-old.
Yeah.
But if I was looking after the patient, I would just prescribe whatever dose I want to prescribe. I don't care what the PBS says. Sorry. I mean, when it's a disease like Prader-Willi, I really don't care what the PBS says because the PBS doesn't have a clue.
But
Let me get into trouble.
The government issues. It's the government that's issuing the script.
So-
And so the government won't
okay.
issue a script
So-
greater than 3.
Okay, so it's going to be until they're 18, and then once they're 18, hopefully they'll pass the test on the glucagon stimulation test. And but if you're seeing me, they'll pass the test because they all pass the test,
Right.
and they'll get the dose they want. So maybe between the age of 17 and 18, it's going to be problematic.
Right.
Okay,
But
let's
quite
hope you can-
frankly, if they get a dose that's below, I don't think they have to have such a high dose between the age of 17 and 18. Haven't most of them finished growing by then? You only need the high dose for growth. And then after that, you need a maintenance dose, the dose that would, on the higher end of the normal range.
So in the Netherlands, we do give a little bit of a higher dose during the age between 18 and 25, 30 to receive peak bone mass.
Yeah. So we have to change it so that kids can get the right dose, and we need the support of your research to talk about it. The way the PBS has it sorted for, I mean, it's great that we can now prescribe it because we couldn't before, so I don't want to rock the boat too much, but we need to change it so that you don't have these issues between the age of 17 and 18. So I would say, yeah, it's very tough.
Thank you. Are there any other questions?
Hello, my name's Monica. Not a question, just a comment in regard to paediatric dosing from when they're transitioning. I agree with our Netherlands,
Kirsten.
we do a transition phase in our centre as well. So we've got a lot of Prader-Willi kids that go from paediatric dosing and they reduce down to 1 milligrams daily as a step-down dose until they transition into the adult services.
1 milligram daily is quite a high dose from our adult point of view.
Yeah.
So that's what you do between the age of 17 and 18?
Not all children, but we've definitely got multiple children's on that.
As long as the IGF-1 stays within the normal range, we keep it up. And I still have patients who are at 1.2, 1.0, until the age of 25, 30, depending on the bone mass, on the bone mineral density.
Great. Thanks. I've learned something.
Thank you very much for answering those questions. It's a complex area, and I hear what you're saying. We've still got some work to do in Australia, but the wonderful work they've done in the Netherlands helped us get over the line to start with, and I'm sure it'll help us improve it as we move forward.